Okay, good morning, good afternoon even, everybody. Crikey, feels like a long day. And a very warm welcome from rather damp and rainy North Yorkshire. I'm sure it's the same everywhere in the UK today. Thank you for taking time out of your day and for finding a motivation to join me in what I think we can all agree has been a particularly difficult week, possibly one of the most stressful weeks we've had since the start of lockdown. I don't know about you, but my head has spun on more than one occasion in the last 7 days. I'm not ashamed to admit it. Um, you know, I too have had my dark moments. So thank you for being here. I think you've all done incredibly well, even to find the headspace to engage in another webinar this week. So thank you. I'm going to do my very best to make it worth your while. We have heard so much in the last few weeks about what we can't do, and it's daunting, believe me, from somebody who hasn't picked a hand scaler up for 10 years. I'm right there with you. But I, for one, have heard enough about what we can't do. And so instead of focusing on everything we can't do, I want to talk about what we can do, because there is so much that we can still do as clinicians. We have got the skills and the resources and the intelligence and the training to do so much for our patients, and that's where our focus needs to be. Not everything is going to be the same, but it's going to be temporary. So we're going to make a difference. Like I say, there's so much we can still do, and so much we can do to make a difference. So I have got my feel good pants on today and my happy hair, pink for Smile Month, and I am going to inject some much needed positivity into our profession, get us all moving again, remind us what brilliant, resourceful, highly skilled clinicians we are, and get some sense of control back into the industry, and hopefully give you some golden nuggets along the way that you can take with you when you finally go back into practice. So here we go. Sorry, my screen's just not behaving. Oh, maybe we're going to stay on the first screen for the whole thing. Hang on. Let's just see what we can do. Nope. I'm going to come out of that. Oh. Okay, so I'm not quite sure what's going on. Perhaps Sharon, you might know why my screen won't move on. Maybe not.
Are you going to load it back up again, your screen?
Yeah, I'm gonna share my screen again with you. That's what I'm gonna do. Because it's changing on my computer, but it's not changing on your screen, is it? Share screen, there we go. Yeah. Sharon and I were just being really confident about how straightforward all these things have gone, weren't we, Sharon? And I'm pretty sure I've just said to you, you've jinxed it all now, haven't you?
Sorry. Okay, is that working?
Right, let's try that again. Yay, there we go.
Okay.
All right, so okay. I'm just had to shift my camera a little bit. So if I'm not looking at you, it's because my camera's in a different place now. Right, okay. So first and foremost, we're off. Yes, first and foremost, I would just like to echo what Sharon has just said and take a moment to thank BSDHT for inviting me to speak to you today. I think they, along with Oral-B, who you might not realise have sponsored these webinars, and without whom probably this wouldn't have been possible, and certainly wouldn't have been coming to us free of charge. I think collectively they have done a tremendous job in managing to put together such a relevant educational programme at such short notice. It's actually quite tricky to pull together. So thank you, BSDHT, thank you, Oral-B, and thank you to all those working behind the scenes. Sharon, Broom, I know you won't want me to say it, but you deserve a particular mention. I think you are rapidly emerging as one of our lockdown superstars, but really everybody involved in putting the programme together, certainly behind the scenes, you've all gone above and beyond what would normally be expected of you in a working day, so thank you. Just quickly, Sharon, thank you for the introduction. For those of you that don't know me, I'm Faye, a registered dental hygienist, like Sharon says, working in private practice in the beautiful town of Harrogate and Wetherby, and a little bit in central Leeds. Now, I am the biggest advocate of minimal intervention approaches in our industry that you will ever find. I believe wholeheartedly that it is the patient intervention that holds the key to our success, and that in managing the patient, actually we manage the disease, and it would take someone with the strength of Hercules to change my mind on that. If anybody knows anybody who looks like Hercules that they'd like to send my way, then feel free, I will not complain. I also have a diploma in counselling skills and human behaviour, which I attained a couple of years after qualifying, when I realised that my job wasn't actually to treat teeth. I realised my job was actually to treat people with teeth. And once I figured out and accepted that I was largely devoid of any experience in managing people, I looked around for a way to rectify that. So off I went to night school. And I have to say, for anyone interested in developing their soft skills, I can't recommend doing something like this enough. It wasn't dental related, so we were a mixture of different students from all different backgrounds. So policemen, women, teachers, nurses, ex-substance abusers, ex-convicts. It was a real mixture, real eclectic mixture, which gave me a brilliant insight and respect for other people's journeys too. And I drew a lot from those people. And I have to say, this course particularly catapulted my people skills and my patient management skills and my communication skills into another stratosphere. So if there's anyone wanting to consider something like that, then my advice is to just go for it. You know, get in touch with your local adult learning colleges and hunt out the courses. Doesn't have to be a diploma. Some of them do 6-month, 12-month courses. I definitely grew as a person, not just professionally, and that can only ever be a winning situation. So that's why I'm here today, talking to you about how to communicate with patients and colleagues and make for a harmonious and prevention-based approach. So enough about me, let's see if we can learn something useful this afternoon. This presentation is going to be delivered in 2 parts, and that's because there are 2 parts to succeeding with this motivation and motivating patients. Part 1 we're going to cover today is engaging and motivating patients, which has to come first. Part 2, of course, is the actual instruction and how we teach techniques and what advice we give. We have to get the first part right before we dive into the second part, and I'm going to explain why as we go along this afternoon. So I Can't Get No Motivation is the title of this presentation. So we're going to take a detailed look at how we motivate ourselves, how we motivate our patients. It's a vicious circle, isn't it? Because we try our best, we always try our best, the patient doesn't engage, which demotivates us, which patients then feed off, which demotivates them, and so the cycle continues. And before we know it, we're treading water, slowly watching things deteriorate, and it just breaks our hearts, doesn't it? So I'm going to try and break that cycle for you. So first we'll remind ourselves briefly about the patient's role in disease prevention and management, and why they need to do what they need to do at home and why that's so important. Then we'll have a look at how we might structure our appointments, so to keep the focus on prevention and keep the patients focused. We'll look at the foundations that need to be laid before our patients will engage and take ownership, and how the language that we use, both body language and verbal language, can influence the outcome. And finally, we'll look at what sort of goals or markers or reference points we can set to help both us and the patients stay focused long after their appointment time is up. So like I said, today is part one, where we learn how to lay those foundations, and then I think it's the 17th next week, or maybe the next week after. Part two will look at how we actually teach oral hygiene instruction. So what is this common goal that we're all aiming for? Let's just remind ourselves, what is it that we're actually trying to achieve every time we see the patient? Whether it's pre-lockdown or post-lockdown, the goal remains the same. So it's about optimum patient health, right? Optimum health is what we're after. And yes, we might want to make teeth look better and feel better, and the patient to look and feel better along the way, and that's okay. But ultimately, what we should all be aiming for is achieving optimum health in our patients, and that shouldn't change during this lockdown period or after this period. We can't let the restrictions that are going to be imposed on us and on the procedures that we deliver redefine our aims and our long-term goals, and the message that we send to patients has to remain consistent. Optimum health has always been our aim, and this period has not and will not ever change that. I use the word optimum because it will be different for different people. Optimum simply means most conducive to favourable outcomes, so the best, effectively. That's the best condition that you can get that patient into, and nowadays that encompasses not just their oral health, but of course their systemic health too. It still blows my mind, actually, that something I do in surgery today can potentially affect a person's life expectancy somewhere down the line. Just take a moment to digest that and then tell me that we don't have a vital role to play. It blows my mind every time, absolutely blows my mind. So let's take a moment, first of all, to think about what type of clinician we want to be and what impact we want to have in our crystal ball golden world. Take, for example, the case of type 2 diabetes. Just go with me on this one. It's not an altogether uncommon disease. It's not as common as periodontal disease, but it's one that's easily missed or ignored, or the symptoms are ignored, and largely brought around by poor lifestyle choices. Not always, but often. A lot like periodontal disease, which, like it or not, in the majority of cases is also a lifestyle disease. It's largely preventable when the risk factors are managed. So if I went to my GP for, let's say, a routine check, I don't know, a cholesterol check, let's say, and he spotted something that led him to suspect an underlying more serious condition, perhaps early type 2 diabetes, I would fully expect that doctor to investigate that. I'd expect them to inform me and to follow up on their suspicions with tests, despite that deviating wildly from whatever it was that I initially went to them with. Now, a patient in this situation's first thought might be that they need some medical intervention, but we all know that whilst that might alleviate some symptoms, actually it do little to prevent the progression of that type 2 diabetes. In contrast, and in actual fact, a prevention-based approach that sought to deliver patient education, understanding of the benefits of physical activity, how to read food labels, diet, exercise, whatever it might be, that would lay the turf for a successful result and an overall better treatment outcome. The disease may or may not require clinical intervention along the way, but the first line approach would be to lay that foundation. Now, perhaps not all GPs would take that approach. Some might reach for a prescription pad. I don't know. I'm not a medic. But ask yourselves this: which doctor do you consider would be more aligned with a patient-centered prevention approach? The one that reached for the prescription pad, or the one that delivered or dealt with the fundamental underlying issues that were causing that problem? Which doctor do you think would achieve greater life expectancy? And most importantly, which doctor do you think you would rather be treated by? I know which one I would pick. Let's bring ourselves back to periodontal disease. We know the involvement of autoimmune responses in periodontal disease processes. So surely we must look beyond alleviating symptoms and what patients perceive as their problem and actually develop an approach that serves to deal with the real issues, the underlying causes, and work towards long-term prevention and optimum oral health. And now is the time, while patients are open to change, to do this. I really, really believe this. Let me say this, the time to do it is now. Because if it's not now, then when is the time? I think as the face of dentistry changes forever, this is our moment, and it is an absolute golden opportunity that we may never ever get again. So we absolutely have to grab it with both hands, and we have to run with it, and we have to run faster than we've ever run before. This is our chance. This is our parting of the waves moment, when we can challenge everything that's been getting in our way, and an entire workforce, we can change those out-of-date patient expectations, those out-of-date industry ideas, those misinformed public perceptions, and actually make the changes that we want to see in prevention-based practice going forwards, because never have we had a shake-up like this before. And everything from our appointment times to what we wear and our approach to treatment and the instruments we use, and literally every aspect of what we do is being torn up and rewritten. More so, never have patients been more expectant to see changes and experience changes. They are literally putty, they are literally at our mercy. Never has the message of importance of self-care and managing one's own risk factors been more relevant and more in the media than it is right now. Never have patients been more aware of the empowerment that looking after oneself brings. Never have been patients been more willing and more well placed to follow instructions and surrender to a new normal, just as we've had to do with dentistry and lots of other parts of our lives. So we must take this opportunity to get patients to accept the fundamental role that they play in managing their own health. They always did, but they must do it ever more now. Get the patients to eliminate their own inflammation, reduce their own pocket depths, eliminate their own bleeding on probing, hand the reins over. You might just find them more receptive than they ever were before. And that goes for our bosses, our colleagues, our practice managers too, who perhaps haven't ever really got it, or perhaps haven't accepted this kind of home-centered supportive approach. They have no choice right now but to accept that things are changing, and they'll only have to look at those patients who've engaged and listened and taken control, and look at how their mouths have survived throughout lockdown compared to the ones that perhaps didn't engage with us. And so it's time to insist that this approach is rolled out to everyone going forwards, and we have to pull out all the stops and empower our patients to manage their own disease. Let's use this post-COVID episode to our advantage. We won't have as many tools at our disposal when we first go back, and the ones we do have are going to be less efficient, and they're going to be more messy. And it begs the question, why should we put ourselves in that situation where we're performing procedures potentially more risky if the patient isn't doing their part? No amount of scaling, with or without AGPs, is going to improve the health of their mouths without their home care. So it becomes a waste of time. And importantly, when resources are limited, it becomes a waste of resources too. So don't resort to being a scaling machine, because that's not what we are. It's not what we do. Why set ourselves back 10 or 20 years simply because the tools we're being told to use temporarily aren't perhaps what we've always used before? Our ethos and our end goal remains the same, and instead we need to use this time as a gift to draw a line in the sand and say things have changed. They've changed forever. This is how it is now. Because if we don't do this now, then I'm just not sure we will ever do it. I know I sound like the preacher, Harry, not Harry and Meghan, the other two, William and Kate's wedding, or was it Harry and Meghan? Whoever it was. Anyway, I'm going to move on, but you hear my voice change because that is how passionate I feel about this. I think it's just an opportunity and we've got to grab it with both hands. So I'm going to try and refocus myself now. Let's just remind ourselves, why is this also important? Periodontitis is an inflammatory disease. It's initiated by oral microbiofilm, right? I don't believe there's a clinician listening today that does not know that. I would add the word undisturbed in there to that statement as well. It's actually undisturbed biofilm that initiates the disease. It's not calculus. Calculus is a secondary product. Yes, it needs removing before the calculus police start on me because it's an obstruction, gets in the way, but it's not what initiates the inflammatory response, and it's not what initiates the disease process, and therefore it's not what should be addressed first. Because if calculus was a problem, then we wouldn't see this, would we? We wouldn't see subgingival calculus becoming supragingival. We wouldn't see resolution around calculus if calculus was causing the inflammation. Don't get me started on the great calculus debate. There isn't nearly enough hours in today, so let's step away from that debate. The disease is initiated by the undisturbed biofilm. So that's where our focus and that's where our patient's focus needs to be. And that's where the focus of every appointment and the epicenter of every treatment plan has to be. It has to. And if we don't start believing this, and if we don't start focusing on it, then neither will the patient and neither will the rest of the profession. So let's do it and let's see what else we've got to back that up. This is a very well-known statement now by Stenman, very widely regarded as robust these days. The most important factor in the prevention and treatment of periodontal disease is the individual standard of daily self-performed oral hygiene. And if you haven't seen that statement in pretty much every other webinar that BSD have produced for us during this time, then where have you been? I'm going to say it again, the most important factor in the prevention and treatment of periodontal disease is the individual standard of daily self-performed oral hygiene. Doesn't say calculus removal. Unfortunately, it doesn't say the brilliant hygienist or the super talented therapist. It says the patient's self-performed care. Get that statement printed. Get it on the wall of your surgeries. Get it on the wall directly in front of where the patient sits in your chair and where they face. Get it on the waiting room wall. Get it written on the back of your appointment cards, on your information leaflets, on your websites, on your uniform. Hell, I would have it printed on my forehead if I could. We've even got it on the back of the patient door. You would be amazed what patients read when they're sat on the loo. My husband reckons he's going to have it printed on my headstone one day because he's sick of hearing me say it that much. Believe me, I would make every patient raise the right hand and recite this sentence before they were allowed in and out of my surgery if I could. In fact, I'd make some of the dentists say it actually every morning and every night when they arrive at work instead of the prayers. Maybe that's a way forwards actually, because believe me, it's fundamental. Get this right, and actually the rest of what we do becomes so much easier. Must be 12 years now since I first went on a Phil Hour lecture at the Royal Armouries in Leeds. I remember it really well because it had such a huge impact on me. It was an absolute turning point in my career where the penny finally dropped and all the missing pieces fell into place. That was the day I switched my focus in surgery from my efforts to the patient's efforts. I switched from clinician-centered approach to patient-centered approach, and it was from that moment that I started seeing a seismic shift in the results and in the health and the stability of my patients, and I have been literally banging on about this ever since. So what do the BSP have to say about this? Well, you should all be very, very familiar with this document, the Good Practitioner's Guide to Periodontology. It's like a perio Bible. If you're not familiar with it, then get it downloaded. It's free and it's a really practical guide to managing periodontal disease and health in practice. You might want to make sure your referring clinicians have access to a copy too. I found it a great resource when I started at one practice where the boss wasn't totally on my wavelength, and he took a little bit of convincing before he came around to my way of thinking. I gave him a copy of this and escorted him onto an Ian Dunn perio course, and well, the rest is history. Anyway, so that's what the Good Practitioner's Guide is, and we should all be following. And this is what it says. So both prevention and treatment of periodontal disease rely on the ability and the willingness of the patient to perform and maintain effective plaque removal. It is our role to ensure that patients become actively involved in the therapy rather than just being passive receivers of treatment. That's a brilliant statement. It's our role. We have to find a way to engage with these patients. It's not okay to just hand out information. We have to make sure they understand. And this comes ahead of everything else that we do. Before we pick up our toothbrushes and start telling them how to clean, we can't be picking up demo brushes or even worse, scalers and removing calculus before we've done the groundwork. That's just building a house on sand, isn't it? This is what I tell my patients now, and this is their take-home message. The treatment of your disease will take place in your bathroom and not in my surgery. That's a really thought-provoking statement to make, and it's an important one because it's about those patients understanding that what I do comes secondary to their home care, and it's about laying the seeds for them to take over the reins and understand that they're in the driving seat. They have to take ownership of this. They have to take responsibility. And yes, I'll guide them, but ultimately there's very little I can do to help if they don't get this bit right. How do I make them listen? How do I make them understand? How do I engage them and keep them engaged? How do I keep that wave upon the sand? That sounds like a line out of The Sound of Music, dear Lord. I've been at home watching musicals too long. Hang on, quick, move on. Okay, before I start singing. So there are 3 pillars of factors involved in getting this right, and various things need to be considered. So there's the patient. The type of learner they are, we'll get into this. So kinesthetic, auditory, visual, how receptive they are, how long you've been seeing them. It's always more tricky if you've been seeing them quite a while and then you try and bring something new in. How important maintaining their health and keeping their teeth is to them. So you must ask them. All of this will impact on how they receive and how they process the information that you give them. Get them into the right mindset first, get them into the right mindset for learning, and that needs to precede everything else, and then they'll be able to absorb what you're saying. Then there's us, the clinician. So our approach, our delivery, our ability to communicate with patients and adapt to their pace of learning, how much energy and effort we're prepared to put in. A motivated patient being taught by a disinterested or demotivated clinician is never going to go well. That's never going to marry up. Patients feed from us. They feed from our passion and our enthusiasm and our encouragement and our feedback and our knowledge and just our overall energy. And if we're not interested, then they're probably not going to be very interested either. And then there's the tools that we use to teach and demonstrate and how we figure out what's going to work best in their situation and in their hands. Not everything's right for everybody, and we're incredibly lucky to have the test drive at our fingertips. I think sometimes people forget what a gift this tool actually is. It's absolutely free. We don't have to be selling Oral-B brushes. We get access to 200 heads every single month, and we don't even have a purchase obligation. It is an incredible resource, and we are so lucky to have it. Before we had the test drive, we were relying on patients bringing in their own brushes, or even worse, demonstrating on models, which has nowhere near the same impact. Anyway, so like I said earlier, I'm going to go into the technology and the techniques in part 2 next week. Today we're going to concentrate on us, the clinician, and opening up those learning filters for our patients. So let's look at us first. Well, because why not? So in order for us to elicit behavior change in others, what we have to do is look at our own behavior and challenge our own approach and ask ourselves, actually, is it us and our behavior that needs to change as well? It's a difficult one to come to terms with, is this, because the patients are the ones not following our advice, right? I told you what to do, why are you not doing it? And I know it's an old cliche, but it's very apt in this instance. If you're not engaging patients then fully, then you probably need to change something that you're doing, because it is an old cliche, but if you continue on that path of doing what you've always done, then you won't be surprised when you get what you've always got. And if what you're getting isn't optimum results, then we need to stop, rethink, change direction. Otherwise, we just stay on this merry-go-round that actually isn't even that merry anymore. And I'm sure many of you can relate to it. I know I've absolutely been there. So back to our trusty BSP Good Practitioner's Guide and what that has to say on the subject of motivating patients. Scientific research has demonstrated that lifestyle behaviour change occurs from within the patient. Motivation cannot be given and it cannot be taught. The key is using communication techniques that stimulate or engage the patient to appreciate the required action needed to reach the desired goal. It's a bit of a mouthful. Basically, we've got to get them interested before we go on to giving the OH advice. So how do we actually do this? How do we stimulate a patient's desire to change? How do we make that desire for change come from within them instead of being dictated to from us? And how do we structure our appointments around education and prevention and not leave our patients feeling shortchanged or complaining that we didn't spend long enough cleaning their teeth, or even worse, have our bosses complaining that we didn't do enough scaling? There's always one. There is always one, but hopefully if you get this right, the majority will see the benefit in what you're doing. I get asked this question so often by hygienists and therapists who know what they want to achieve, but the patients are so indoctrinated into thinking their appointments are about calculus removal that it's like breaking down a brick wall. And that's why we must take our opportunities when they arise, like the one that we've got now, and use them to our advantage when the resistance actually is at its least. So where do we start? What can we change about what we do that will then influence our patients' behaviour? I know you hear the word behaviour change and you switch off and you think, well, that's all well and good in theory, but what do I actually do in surgery to apply this brilliantly researched and evidence-based behaviour change model? I haven't got time, right? I know, I've absolutely been there. For a start, we got to cut through the waffle. I'm a good one to talk, and make it personal to the patient. Otherwise, it sounds like all the other white noise that comes out of clinicians' mouths, and you'll just lose them. They'll be quietly planning what they're going to have for their tea when they get home instead of absorbing what we're saying. The desire for improvement comes from within them. And where that desire comes from, that's our job. And we have to start filling their heads with the right information that's relevant to them. So hold back before you tell them how to fix the problem and clean the teeth. You've got to help them to understand that there's a problem there in the first place, because that's where the desire to clean well will come from, and the desire to improve things will come from. So let's look at some ways that we can start to get some of that information through to them. This is my list, this is what I do in surgery, and it's what works for me. You might be able to add things into this, and feel free to let me know what they are. First of all, we need to know what we're dealing with before we can start to tell our patients. So number one is, of course, screening and diagnosing properly. And this may seem obvious, perhaps even patronizing to some people. I know I'm speaking to the converted here, but oh my days, does this get overlooked or rushed or kind of half done but not completely? You cannot diagnose without screening and examining properly. Wrong diagnosis, wrong treatment. It's as simple as that. Patients' conditions and treatment needs they don't stay the same. They're transient. They change constantly, and we have to move that with them. We can't use a chart from 2 years ago to determine a patient's needs today. We've got to track and monitor constantly and feed that information back to our patients. You have to remember that one of our duties of care is to keep that patient up to date and informed. And we need to know what their current status is, because how do we know if that disease is progressing if we don't monitor it? That's the first point. But more importantly to what we're discussing today is the beauty, and if you've heard me speak before, you will have heard me banging on about this before, the bleeding chart. The easiest and quickest and most reliable way to check the health of a site is to check for bleeding. It is so quick, it is so easy, it's largely indisputable, and it is so powerful for patients to know this number. You're going to hear my voice change again now because I am so passionate about the role that bleeding scores play in motivating patients, and why I think they are massively underutilized. We're talking about motivating patients. To do that, we have to speak their language, and we have to use terms that they understand and that make sense. Nothing that's in our body and is healthy should bleed, really, whatever we're doing. So a bleeding score is something tangible that a patient can grab hold of, because patients know that and they can make sense of that. Um, and I know patients say it wasn't bleeding until you prodded it, but it was, and we know that, and they'll know it too by the time we've done educating them. I tell them, if I rubbed my face on an eye and it bled, I wouldn't think I better stop rubbing my face, it's bleeding. No, I'd think there's something wrong with my face. I need to go and see my GP and find out what's wrong with my face and do whatever I've got to do to get a healthy face again. Patients don't understand disease processes, but they do understand that bleeding's bad and not bleeding is good. And the other thing they understand is percentages. The computers these days, they work the percentages out for us, thank heavens. Thank heavens the days of having to work this out for myself are gone. If you tell a patient unhealthy gums bleed, it's like telling a patient that smoking causes cancer. It goes in one ear and out the other. You have to personalize this information and make it about them by saying, you know, things like, I've taken your bleeding score today and it was 30%, 40%, 90%, 100%, whatever it is. Suddenly they're listening because it's personal to them. If you then back it up, ideally we'd like to get this score under 10% or as close to zero as we can. That's where we would consider you in this healthy zone. Then it also gives them some perspective, sets very clear goals for patients. That 10% mark is a very clear goal for patients. Not all of them will make it, and sometimes we have to make adjustments, so we've got to be careful here, but that's generally what we aim for. And especially during this post-COVID time, we can be very clear that the best thing for their health is that the level of inflammation is reduced, and we need their help to get this bleeding score down, under 10% ideally, before we can do anything clinically. This might not even be a big perio case. This might be a gingivitis case. The bleeding score is just as relevant to those patients as it is to the perio patients. I've read posts on forums, and I've had notes from referring dentists saying NAD, BPE code 1's all excellent. BPE code 1 in all sextants means bleeding in all sextants. What part of bleeding in all sextants is healthy? We need to stop thinking about these patients who present with intact periodontium but bleeding gums as healthy. That's not representative of health. Absence of bleeding doesn't always dictate health, but it's a pretty good indicator. In fact, 98.5% predictive ability. Of course, presence doesn't always mean active tissue destruction, but it does mean inflammation, and where there's inflammation there's potential, and it's our job to intervene at that stage. Patients need to know that it's there and what it means, and what can be done about it. Give them those percentages. It adds perspective. Think back to the diabetes analogy. My doctor said your blood sugar's a bit high, I'll keep an eye on it. I probably wouldn't be over alarmed if he said your blood sugar's 17, which is almost as high as it could go, and it should be under 4. You know, I'd be doing everything in my power to change it. We have to be real with our patients, and we have to be real with ourselves. We have to take these scores seriously. Every single one of my patients knows what their bleeding score is. Every single one of them, or every one of them's told anyway, whether they remember. They know that our goal is to get it under 10% and keep it there. For some high risk perio patients, actually I take that percentage even lower, but that would be very personal to them. On the whole, we aim for under 10%. Patients understand that it's very easy goal. It's very easy for them to understand where their gums are at on a scale by using percentages, and it gives them a goal. Don't get me wrong, they don't all return after one visit with bleeding scores that are under 10%. For some patients, it might take me a year. It might even take longer for big perio cases to get them there. But as long as they're heading in that direction and they understand what we're trying to achieve and the journey that they're on, then I'm going to be happy. It also makes for very good communication between the dentists and the hygienists or therapists too. The dentists I work with now pay a lot less attention to the pages of charts that I've filled in, and they turn straight to the bleeding scores to give them a quick overview of where that patient's at. They know if that score's around whatever 80%, they need to reinforce what they know I will have said, and they know if it's hovering down around that 10% mark, then it's time to high five the patient or fist elbow pump or whatever it is we've got to do these days. They don't always actually have to look anymore now. Patients often will just tell them. So the dentist might ask, but often the patient will say, oh, you know, I'm a bit disappointed myself, my bleeding score's gone up, or equally they'll be beaming because it's come down, and whatever. It makes me smile because it means that they're thinking and talking about bleeding and inflammation. And they get competitive too when Mr. and Mrs. come in, and it's nearly always the Mrs. asking what her husband's score was and telling me hers better be lower because he hasn't been using his sticks. And it's absolute music to my ears. Once you get everyone talking about bleeding and bleeding scores, it's an absolute game changer. Patients start asking me, they come in, you know, what can I get it down to? I can't wait to hear what my score is, and so on. And honestly, it is one of the simplest and easiest changes to make. If you're not doing bleeding scores routinely at the minute, I urge you to start because they are so motivational for patients. They really are. So some of the things, really easy thing that we can do to engage a patient, and actually we're not very good at this. We're very good at it when it comes to periodontal disease, but giving other conditions a name and making it real is also very powerful. Mrs. Smith, I've examined your gums today. I've taken a bleeding score, which is 40%, and that tells me that you've got some gingivitis. Don't panic. It doesn't mean your teeth are about to fall out. It's completely reversible, but it means that we need to take a different approach today. So let me explain what's happening. And off we go. We're talking bugs and inflammation. I think we've become so scared of using jargon that patients can't understand that we've actually gone too far the other way, which almost trivializes it. And you wouldn't hear the dentist trying to get a patient to return for a filling without actually telling them there's a hole in the tooth or there's caries under the crown. That would just be ludicrous. And we should be no different. So let's not trivialize this problem, because for some people, developing periodontal disease or gingivitis really is the end of the world for them. We don't have to get technical, but you'd be surprised how incredibly receptive patients are to being told that they've got a condition or they've been diagnosed with gingivitis or gum disease. It's true. We're not making this up. Some of them are horrified, yes, but we're there to support them through the initial shock and to guide them and reassure them. I cannot tell you how many conversations I have had with patients about their bleeding gums, and then only when I call it gingivitis do their eyes widen and their ears prick up. And I'll say, has anyone ever discussed this with you before? And they'll say things like, well, yeah, I've always had bleeding gums, but I've never had gingivitis. And oh my God, the cat got gingivitis and the teeth fell out and my gran had gingivitis. And it's funny how they were okay with having bleeding gums, but they're not okay with having this gingivitis. Don't get me wrong, this is not about scaremongering or making things sound worse than they are. It's about getting real with patients and putting that condition, whatever it is, on their radar. Suddenly, you'll find they're less concerned about that stain between their lower anterior teeth and more fixated on the fact that they've been diagnosed with gingivitis or whatever it is. And that's the way that it should be, because I'll tell you what they do. Even if they're skeptical in surgery, even if they tell you the dentist never said that, and I don't really believe you, I'll tell you what they do. They go home, they get on the internet and they Google it. And that is the absolute best thing that can happen, because guess what Google tells them? They need to brush better. They need to go and see the dental hygienist or their therapist or their dentist. It reinforces what you've already told them. It also means they're thinking about it after they've left the surgery. They haven't walked out of your surgery, forgotten every word that you said. They've gone home, mulled it over, and that means there's a much better chance that they'll take your advice on board. This might sound really basic, and I guarantee you will have written it in the 5 pages of notes that you wrote after they left the surgery, but you might not have actually said the words to your patient. The power of giving this a name is phenomenal. Patients come back, and before they've even sat in the chair, they're asking me, what's my bleeding score and has my gingivitis gone away? Patients don't want it in their mouth. They don't want it there. And believe me, that is an engaged patient. Remember, I haven't picked up an OH aid yet. All I've done is diagnose and inform, but already the patient's asking me what can be done about it. What can they do? What can I do? What can be done? And they're already hoping for a solution. The receptors or their filters are starting to open like a little flower, and that's exactly where we want these patients before we go on to teach them how to clean the teeth. Like I said, this isn't about scaring patients. So I'm always very gentle when I deliver this information. I'm aware that some patients will be really sensitive, but that's not a reason not to give it. It's part of our job. And if we don't recognize it and address it as important, then neither will our patients. We shouldn't feel guilty about what we found. We can empathize, but it isn't our doing. And that's where our incredible supportive communication skills come into play. Always back it up with written information. Patients, especially if you've shocked them with a diagnosis that they weren't expecting, won't necessarily take in everything you've told them, and they'll think of questions after they've left the surgery. So good comprehensive leaflet. There are ones you can download on the BSP websites. We wrote our own, taken from various ones that have been posted on forums or given out at courses, and we've just sort of tweaked and adapted a little bit to suit us. They're written in very, very simple terms. The ones that I give out, they answer common questions like, will mouthwash help? Why can't I just have antibiotics? Why do I need to see a hygienist? Will my breath smell? You know, these questions that really matter to patients. And it also reinforces the message of the importance of their home care and the role that they play. I actually had a patient just before lockdown and came to see me because he'd read his wife's info leaflet that she'd left lying around, and he'd recognised some of the symptoms described, and so he'd self-referred, and that was really nice. And they came together. They called it Gum Club. Apparently it was easier to go to than Fat Club, which they also attend together. Anyway, that's another story. I love my patients. They make me laugh every single day. Write it down. This is a biggie. We'll look at this sheet in a lot more detail next week in part 2. This is my personal OH prescription that I hand out along with the information I've given about gingivitis or peri. So it's got their name at their top. My nurse generally fills this in while I'm speaking. It's got the date, it's got their plaque and bleeding percentage written in. And let me tell you, if you think they don't like hearing what their bleeding score is, they really don't like seeing it written down, but it reinforces it, it makes it real. They'll nearly always make that sound when they see it, or they'll often follow it with, oh, that's not good, or a similar comment. But that's okay, because by the time I give them this, then they've had their OHI. So I can agree that it's not ideal, but remind them that they've got the power to change. And if they do what I've shown them, 10 days, it'll be a different story. And I can't wait to see the score come down, and always finish on a bit of a high. The rest of the sheet has a few words reinforcing the home care message. And then it's their personal OH prescription. So while I've filled in what toothbrush I've recommended, toothpaste, you know, if I've rarely told them to use a mouthwash or subgingival cleaning, it'll be written in words they can understand. So it'll say, on your last tooth, at the back, push this brush under your gum. You know, it will always be in words that they can understand. And then down at the bottom, I do a very site-specific incidental map. So working from the first space on the top left, and we'll write literally 1 grey, 3 purple, 2 green, whatever it is, and go along, so that they've literally got a map. And of all the things that I've done for patients over the years, I've got to say this little scrap of paper is the thing that they absolutely cling to. It gets stuck on bathroom mirrors, and it gets taken to work with people, and they come back with these scrappy bits of paper saying, can I have a new one because this one's really messy. They really cling on to this. It's like the homework, and I didn't see it coming, but actually it's the best thing. I've been using these for maybe 4 or 5, maybe slightly longer years now, and they absolutely work. They work with confidence as well, where I might have said you need a 3 grey on that top left, and they come back and say, oh, I only used 1 because you must have got it wrong. Tends not to happen so much when it's written down. Okay, so next up, this is my favourite one. Stop saying the word calculus. or tartar or whatever it is that you want to call it to patients. And while you're at it, ban the words scale and polish or quick freshen up or any of those hideously outdated phrases. Just stop it. Ban it from the practice. We don't have a swear box in the practice where I work. We have a calculus box and the word is banned. And if any clinician uses that word with my patients, and if any patient comes to me saying the dentist said, I'm doing okay, I've just got a little bit of tartar to clean off, then said dentist puts £1 in the calculus box. And don't think I haven't had a couple of fantastic nights out on the earnings I've made in that calculus box. Because why? Why would we say that to a patient when it bears no reflection on how healthy or unhealthy their mouths are? In a period when we are battling to fight off old-fashioned ideas about what a hygiene appointment actually does, would you focus on something that isn't the most important thing and deflects completely away from the real issue? If that's what the dentist or the patient or whoever focus on, then that's what the patient thinks is important. The dentist can say anything else. So they can comment on any other part of the patient's periodontal health, but they can't focus on calculus because it just feeds the patient's expectations. I don't want to hear it. I don't want to hear them saying, I want to hear them saying things like, I can't see much bleeding today, Mrs. Smith, or your gums look really pink today. They're a lot pinker than they used to be, or the gum pockets look like they're shrinking. Or similarly, if things are getting worse, they might be saying your bleeding score looks like it might have gone up, or there's some pus coming out of one of your pockets, or whatever it is. This tooth feels more mobile, whatever. But they cannot say anything that refers to the supragingival calculus lingual to the lower anteriors. It is banned. And you know what happens once we change our language? So does the patient. And once we change our focus, then so does the patient. If patients do mention calculus, then we'll talk about why it's there and that it started out as a soft removable biofilm and that there are techniques I can demonstrate that will reduce it. But that's if the patient mentions it. What we can't do is give the impression that all that needs is a quick scrape to remove the calculus without addressing anything else in the mouth. I haven't even got a bleeding score yet. If the patient sees the dentist first, who doesn't mention bleeding gums and only mentions calculus, and then they come to me and I diagnose gingivitis and focus on OHI and don't focus on the one thing that the dentist told them they needed, then it becomes very confusing for the patient. And it either belittles the dentist because they believe in what I'm saying, or it belittles me. And neither of those is an option. It's not a good option anyway. This is particularly important in cases where there is a perio diagnosis. We have to have this really united approach. If the patient comes into the room thinking I'm going to pick up my magic scalers and fix everything because the dentist said that's what they needed, then we're already on the back foot. And it's so easily done. None of the dentists I work with are purposely trying to sabotage my attempt to improve the patient's oral health, but they might be saying phrases without thinking about it. What they think is actually praising a patient is making it a bit more difficult for me. And so, you know, they might be saying things that without realizing the impact that those words have. So please talk to your colleagues. Don't be afraid to explain where you're coming from and ask them for their help to shift the patient's focus too. And if that doesn't work, then hit them where it hurts and shake a calculus box under the nose. It works every time. They see me coming and they run. Especially the younger ones, poor darlings. They're terrified of me. Anyone that disagrees with me, I tend to quote one of my all-time perio idols. This is Professor Mombelli, and I tell them what he stood up and told everyone at Euro Perio 5 in 2006. I'm more interested in the living bacteria than the petrified ones. It's actually one of my favourite responses, and I use it with patients too. Not necessarily quoting Professor Mombelli, but I will say to patients we need to focus on the living bacteria that you can't see first before we get to the petrified ones that you can see, and they do seem to understand that one. Now, I had a little debate with myself about whether or not to leave this one in here, because at the current time with restrictions on polishing and reducing patients rinsing, I understand this might need to take a back seat for those going back certainly those going back on Monday. That I accept. We don't want to make things more difficult for ourselves. But I've left it in because for those of you that have heard me speak before, you will know what an absolute advocate I am of disclosing. And also there'll be some listening that aren't going back on Monday, that are going to wait until that infection rate comes down, when we will have a little bit more scope to play around with. Honestly, between bleeding scores and disclosing solution, it's a toss up between which one I think is the most underutilized. I know what you're thinking. Patients don't like it. They haven't got time to clean it off. I haven't got time to do it. It makes a mess and so on. Remember our focus here, engaging patients. That's what we're aiming for here. And nothing competes with the power of seeing what they've left behind, especially the ones that think they haven't left anything behind. Seeing really is believing. And also learning about growth patterns and where the majority of the biofilm collects, and how easy it is to think that you've removed it only to find that you've left it behind. Patients are really not as adverse to this as you think they might be, especially after you've told them they've got whatever, an 80% bleeding score and they've got gingivitis. If you're confident about the benefits, your patients will be too. A lot of the compliance is in the language that we use. So if you say to a patient, I'm going to disclose you to show you all the plaque that you've missed, they'll immediately sink into child mode and you'll get some resistance. I never ever say that. Just change the language a little bit. Think about how you're saying things. So I'm going to apply some dye to your teeth to help me to see where the living bacteria is, so that I can make sure that I get rid of it all. Is a very different message to give to a patient. It's like when I go to the eye hospital and the doctor puts the yellow dye in my eye, it makes my eyeball go yellow for 30 minutes. There's no part of me that would request that he didn't do that. I just accept that it's part of his diagnosis process and I just go with it. Disclosing's not dissimilar. Patients get used to it. My patients come into the surgery expecting it. They understand that it's part of what happens. And again, that's because we have such a biofilm focused approach and prevention focused approach, and they know that I can't necessarily see all of that biofilm without some help. Once it's applied and there's obviously disclosed plaque, then I would bring my patient in and ask if they would mind if I show them what I can see. They never say no, but I'm always polite and tactful, and I ooh and I are along with them and pretend I'm surprised at what is uncovered, because I didn't expect that either. And of course I knew it was there incidental. They haven't been using the brushes, but they didn't need to know that. And the last thing I want is for them to feel embarrassed or dirty. I would hate that. It would undo all of my hard work. So our body language and the words that we use, we have to be very carefully chosen as well. I disclose every single patient comes through my door. I don't always share the plaque score with the patient. I much prefer to focus on the bleeding score. It gets confusing giving them too many numbers, and the bleeding's a better measure of where they're at in terms of tissue health. It's genuinely really quick and useful and massively underutilized tool is disclosing. I use the little pre-soaked sponges because I'm all about saving the planet, and I don't like the extra plastic waste and the mess that comes with the liquid solution. It needs to be quick and slick and understated for it to have the impact that we want it to have. So less is more in this case. And there's lots of studies that back up dental plaque, the benefits of disclosing in terms of diagnosing plaque and removing it. Okay, so now this is the stage where we come in like a knight in shining armor to rescue the day. So only, and I mean only, after we've properly diagnosed, informed the patient, given the condition a name, whatever that might be, disclosed, fully explained and engaged and said all the right things and got them listening, do we then gallop in on our white horse and save the day? If we wade in with our OHI before the patient really even understands that there's a problem, and before they really even understand their role in all of it, it's just white noise. And all the patient can think about is why is she making my gums bleed, and when's she going to clean my teeth, and shut up talking. Remember this statement from earlier, the desire to change has to come from within the patient. And until we've flicked that switch to on, and they're informed and they have some kind of understanding, that then it's simply just never going to happen. And whilst ever they're switched off and disengaged, then you might as well be talking to the Bunsen burner, quite honestly. I know this might sound like a lot of groundwork, but a lot of it only needs doing once. And once you've grasped their attention and their understanding, then they'll be asking you the questions. And they'll be working hard to do their part. And your part becomes a bit of a doddle, really. But you have to put the hours in at the start. And this is what I mean when I say the time is now. Patients are expecting changes. And now more than ever, we can justify why we're using this time wisely to get the patients to understand their role and change their behaviour. And it's literally never been more important. So what solutions are we going to give? Like I said, this is the point where we go from being the devil in disguise to the absolute knight in shining armour. It doesn't always happen immediately. Sometimes they need to go away and have a little think and have a little research and then kind of come crawling back. But it does generally happen slowly but surely as they see the results and they hear our praise and they hear the praise from the dentist. Then the relationship starts to blossom and they start to trust you and rely on your feedback. What can we do at this stage to help them take those few baby steps at first? And especially if this is a very big perio case and they've got all this information hurling towards them at the speed of light. The first thing we're going to do is reassure them and help them to feel supported and help them to understand that they're not alone and that this is what we do and it's what we do every day and that we're on their side and we're going to help them, and that's very, very important. I tell my patients all the time that we're co-pilots. They're the captain of the ship or the plane, so they get the final say, but I'm there to assist them and to guide them and to take the strain when they need me to take the strain. We're a team, we're partners, but their job is just a little bit more important than my job in this particular partnership. Patients love that. They love to hear that they're more important. And I'm almost asking them to help me. If ever you study this stuff in detail, it's incredibly powerful how handing power over to someone in this type of situation and giving them this sense that they're responsible for someone else as well as for themselves, it tends to bring out our human warrior instinct to save others. And it's all very deep, but it's absolutely fascinating. And the power of the language that we use at this stage really can make all that difference. So use words that they can understand, explain carefully, give them time to respond, don't overcomplicate. You can explain this in just a couple of minutes. You know, there's some inflammation there, there's some bacteria there, this is your body responding, we need to get rid of the bacteria to get rid of the inflammation. It doesn't have to be long-winded and complicated. Think about your body language, sit the patient up whilst you're speaking, especially if you're delivering this sort of news to them. Because unfortunately in dentistry, one of the first things we do is lay our patients back, and it goes against our animal instincts. If we were a tiger or a lion in the jungle getting surrounded by a pack of hyenas, which, let's face it, is how the patients see us, the last thing you would ever see those patients do is that lion do, sorry, is lay on its back and expose its torso. It goes against all of our human instincts in a vulnerable situation to lay back and expose our torso, which is why patients that aren't even normally nervous are sometimes a bit nervous. So sit them up so that they're on your level. Ideally lower your chair so you're slightly below them. This is all about power and body language, very open body language. So no crossed arms, no closed positions, no scowls. Even if they're annoying you, try and lose the scowl. Position your chair in front of them as well, so you're not talking from behind them. Like I say, ideally just a little bit lower so they feel less intimidated. Lots of mirroring, lots and lots of listening. Listen to what they say, listen to their fears, listen to their anxieties and their concerns. You actually will learn a lot about that patient if you listen to them. And feeling listened to is really very powerful in building patient relationships. So you know, give them time to speak, ask them if they understand, ask them if they're following, ask them if they want you to say anything differently. Make good eye contact and reassuring acknowledgements. And look, most of this you'll do automatically without even thinking about it, especially if you've been doing it for years. But it's always good to remind ourselves and remember how important the tone of our voice is too. You can tell a lot. We know this from patients' tone. We know when they're upset about the wait that they've had for 5 minutes. I don't think patients can't pick up on whether we're having a bad day or not just from our tone. And now we know from the guidelines out this week, the low risk, so it can be done either at a 2-meter distance or wearing basic PPE. And I'm really relieved about that, because I was trying to think about how I was going to get around this communication issue if I was dressed up like Neil Armstrong in the surgery, and I think it would have caused all sorts of communication problems. So I'm really delighted actually with the guidelines that have come out, and it's the one thing that I looked at before I looked at the AGE restrictions. I went straight to what do I have to wear when I'm delivering OHI and communicating. We'll get on to what we say in the OH demo and how we say it in part 2 next week. So I'm not going to dwell on that this afternoon. How are we doing for time? Oh, crikey, we're all right. We've got a couple of slides to go and then we're done. So what stops patients from engaging? A lot of these we can eliminate if we just put the effort into the first part before we dive into OHI. Optimistic delusion won't happen to me. My grandma had a teeth till she was 90 and she smoked 60 a day, and it won't happen to me. They need a lot of talking and educating. Patients that don't understand instructions, we've got different learning types. So we've got visual learners, we've got auditory learners, we've got kinesthetic learners, and this is why listening to patients is important, because if you can pick up just by the language that they use, if they're saying things like, I don't like the look of that, then they're probably a visual learner. If they're saying, I don't like the sound of that, they're likely to be an auditory learner. We've all got a little bit of all of them, but usually one of them is quite prominent. Largely, we have a lot of kinesthetic learners. I don't like the way that it feels is quite a common one to hear. And if you can work out what learning type they are, then you can direct your education. You know, the visual learners and the auditory learners tend to like things written down and like to take things away to digest them. The kinesthetic learners, you might as well, you know, give them last week's newspaper, because often it's how it feels and that they're focused on. So see if you can't try and work out so that you can channel the instructions in the right direction for them. Patients didn't remember instructions. Let's accept that we have different learning abilities. Not everybody is academic. Not everybody absorbs information at the same rate. A lot of our patients, my parents, for instance, they're in their late 70s. They come from a generation where you left school at 14, you got a job, and education just wasn't part of their adult lifestyle, and so they don't always absorb information the same way, and we have to make exceptions for that. It might take a couple of visits. It might be that there are different learning abilities there, so we try not to get too frustrated with them. Impaired manual dexterity, so the patient gives up. We'll come on to that at the next lecture that I give. Didn't understand the consequences. This is a common one. If we didn't explain what would happen if we didn't eliminate this bleeding and inflammation, and it's just us banging on about your gums are bleeding, you need to clean, then they're going to struggle to engage with that, and that's everything that we've already said today. Apathy, these are often the easiest ones to treat, because they kind of say, yeah, I'm not really worried, I'm not bothered about dentures, I quite fancy the idea, so I'm not really interested. They're actually quite easy to treat, those ones. You just document, you know, patients not interested, get them to sign their lives away, and that's it. We don't have very many of those. And then you've got your total denial, and this is usually about poorly informed, and again, you know, with all of the communication we've taught today, they generally come out of that denial zone. They might not always admit it, but that's a power trip. They will come out of it eventually. And when they do, why don't they follow the instructions? Well, instructions are meaningless and easily forgotten if they don't understand the context. And that's why everything I've said today is really, really important that it comes first. The natural response to force is to resist. So don't push this. If we go in saying you have got to do this without any explanation, they're going to resist this. They're probably going to book in with the other hygienist who doesn't tell them off. Non-specific fear campaigns, we know they don't work. Stop smoking or you're going to get cancer. It doesn't work. You need to floss every day. It doesn't work. They have to understand the context. They have to understand why they need to do that. Mrs. Smith, this implant that you just spent £3,000 on, implants fail, and if you don't do X, Y, and Z, then there's a chance that you're going to get inflammation and that your body will reject this implant. That's a specific for that patient to take on board. Non-specifics just tend to not work. And let's remember that learning a skill maybe only takes minutes, but actually changing a habit can take weeks. So we have to be patient and give them little tips and baby steps. What can you do between now and next week? What do you think you can do in this time? Just give them a very specific goal to work to, because it can take time. There are three kind of key factors that underpin people's motivation to change. It's got to be important to them. It has to matter. So that's why we do all the explaining that I've talked about today. They have to feel physically competent. So they have to actually have the skill or develop the skill to be able to do this thing that you're asking of them. Otherwise, they're just overwhelmed and they give up. How many times we heard patients say, I just couldn't do it, so I didn't do it. And that's where next week's lecture comes in as well. And number three, they have to feel confident. So they have to believe that by pushing that brush into a pocket, they're not going to somehow push bacteria up under the gum and cause recession and then stop doing it. So we've got to feed them some confidence as well. And all these factors can be addressed if we take the right approach from the start with these patients. And a lot of it comes from the confidence and the competence and the enthusiasm that we show in surgery, because that's what they're feeding. That's what they're feeding from. Crikey, I nearly knocked my computer over there. Goal setting, again, we'll come on to this next week. There's lots of different goal setting models that you can use. You can research this yourself and find the right one for you. It's got to be right for you as well as for your patient. There's different books you can look at. Jeannie Suvan wrote one called Behaviour Change in Dentistry, which is very, very, very good. And there's a couple of models in there that you could work with. We're all kind of at different levels with this. I really like the GROW model, which isn't specific to dentistry, but I think it encompasses all that we're trying to achieve. So G is the goal, where we want to be, in this case optimum health. R is the reality, so that's where we are now. What's your bleeding score now? What are your pockets like now? What's the reality of the current situation? O then are there options. So what are their options for turning this around? They could do nothing, they could do something, X, Y, and Z, treatment, referrals, whatever it is, whatever we're dealing with. Always give the patient the options. Never tell them what they've got to do. Tell them what you think they could do and let them decide and be honest and be real. And then W stands for will. So how willing or committed are they, and how willing and committed are you? Because it really is a team effort, and what are they willing to do? Try and get them to commit, even to the smallest change. Like I say, it can be a huge leap. So what are they prepared to commit to, and what firm plan are they going to put in? So 5:30 every morning after they've walked the dog, that's when they're going to go and spend 10 minutes in the bathroom or whatever it might be, because they can't reach that goal G until they make some commitments. I have this model on a laminated sheet, and sometimes I show it to patients when it's particularly relevant in their journey. Not all, don't bombard them, but especially for visual learners, they tend to find it quite useful. Like I say, this is just one that I use. You can find your own. There's tons of research you can do. There's all sorts on the internet. You're probably already using part of the GROW model without even realizing it. So whatever you do and however you choose to move forwards with this, set your stall out now. Get yourself a protocol and stick to it, so that each time that patient comes in, you follow the same protocol. They'll just get used to it, especially your maintenance patients. So my protocol: number 1, examine; number 2, disclose; number 3, motivate; 4, biofilm disruption; 5, calculus and stain removal; 6, recall setting. And I do it in that order because that's what I deem is the most important order in which to do things, from most important to least important. The majority of my appointments are taken up with the assessments and education and motivation, and that's largely because I put the groundwork in at the start, and now these patients are very, very highly maintained, so there's very little that I need to do on them now. Remember this: motivation isn't static. It can vary as individuals are affected by other relevant life stresses as well. I know I'm preaching to the converted here, so be prepared for peaks and troughs, and be prepared for the impact that that has on their disease status as well. I don't think I really need to say much more, except that goals aren't static either. They need to change as the disease status changes. So, you know, we have to be prepared to revisit and retreat and remotivate and change direction like the wind. And, you know, we're all contortionists, so we're very, very good at that. So, like I said at the start, and I will say it again, this is our time to rewrite the script. I truly believe we will never get this opportunity again, not in my working career anyway. I want us to look back and see this as a time of revolution. I think we should start the great perio revolution. And yes, we may have to step back in time with the instruments we use for a period of time for those of you that are going to go back, but it won't be forever. Don't let that stop us from pushing forwards with the standard of prevention-based care that we can offer. Don't let yourself be drawn into the negativity that's out there, that's focused around all the things we can't do. Stay focused on what we can do. We are great. We are resourceful. We are highly skilled, highly trained, highly adaptable to change. We cannot let go of our common sense and the common sense that we applied every single day in surgery before we were hounded with protocols that came at us like a speeding train. Don't lose sight of the clinician that you are and the clinician you want to be. And second to a medical theatre, we have the best cross-contamination control of any profession in the world. And what's more, I believe that we have the best antibody of any profession in the world too. So don't let fear and scaremongering hound your desire to work and to make changes. Remember why you went into this industry, and think of all the patients that you've helped along the way. The nation needs us to be strong and united and professional, and we will absolutely come back from this with our perio revolution. In the middle of difficulty lies opportunity. This is one of my life mottos. Use this moment to make a stand and revolutionize the way that you are prepared to move forwards. Go back to work stronger and more determined and more confident than ever. We can absolutely do this. I've seen lots of questions about my personal situation coming up as I've been talking as well. So I'll answer it now so that I don't have to answer it time and again in the questions. At the moment, I am self-employed in 3 practices. I'm not yet returning to work. Whilst infection risk is at level 4, the work I do is not deemed by the practices where I work as urgent enough. That doesn't mean that what we do isn't important. It means that it's not deemed urgent enough at the moment. Any urgent cases will be seen by the dentist who's already in and working and doing his AGPs and whatever else he's doing. As soon as the infection level drops to 3, we will consider seeing my perio patients, going back in to see my perio patients or those most in need of hygiene services. We won't resume routine hygiene care at the moment until the infection level drops to at least 2. That is me and my very personal situation and what my bosses have asked of me. Personally, I think it's the right one for us. We're very little small practices, and so it strikes the right balance between being viable and adhering to guidelines and continuing to provide a service for our patients because we've got that duty of care. What I am doing is Zoom appointments at the moment with any patients who either want them or who the dentist feels need them. The advice that we can give over a video call actually saves 30 minutes or so, and I can see this carrying on once we're back in surgery. Lots of them that I'm speaking to a mouth that I know very well, patients that I know very well that are worried about a bit started bleeding, or this pocket that I've been going on, or can you tell me again what to do in this furcation? Some are completely new cases. I haven't been able to examine them, but that doesn't mean that I can't explain the disease process and everything I've talked about today and get them started at least thinking on the right pathway. And we have a system in place where I can then email the practice with any OH advice that I've given, aids that I've recommended, and the patient calls up and pays, and then the practice posts it out. It's been going incredibly well, actually. Patients, I think, have been more receptive to receiving the information because they have to accept that the onus is on them because there's no face-to-face at the moment. And also, I think they're in their own home, so it's a less threatening environment. It's not a service that we currently charge for. That may well change in the future, but we're just trialing it at the minute. So we'll need to address that at some stage if it continues. For now, I'm just glad to be helping my patients, but also helping my bosses. They've been incredibly supportive of me throughout my career. They've embraced my boisterous personality and my approach, and they've always paid me well and given me a nurse and allowed me the freedom and the autonomy that I wanted, and they've embraced the changes that I've pushed for, and they're going through a dreadful time as business owners, and this is just my way of giving a little bit back and my way of showing some support at a time when they need me most. We're a family, and that's what families do for each other. Everyone's situation is different. I don't suggest it's right for everyone, certainly not those that feel that they're already being taken advantage of or don't feel comfortable going digital. Perhaps it's not right for them, but it does feel right for me. I've always been very proactive, and giving a little back makes me feel great, and also I feel a little bit less lost in the system. It reminds me what an important role I play in delivering patient care, and I really have had some wonderful messages of gratitude from patients and from my bosses, which has lifted my spirits enormously too. So don't be that wallflower. Be proud of what you are, and carve whatever new pathway we've got to carve. You know, what's that saying? Something about if opportunity doesn't knock, build the door. I don't know what it is, but whatever it is, I think it defines me at the moment. Don't let these restrictions define you, and don't let them dampen your drive and determination to be a phenomenal clinician. You can absolutely do this. We can do this. So part 2 of Push Don't Brush. Part 2 is called Push Don't Brush, and that's because that's the technique that we are specifically going to talk about when we're looking at the test drive. But we're also going to look at where are we at with mouthwashes, and where are we at with irrigation, and how on earth do you teach a patient to subgingival brush, and you know, what is the right size TP to put through, or whatever incidental brush. So we're going to go over all of that next time I speak to you. If I haven't put you off, and you all come back and listen to me next time. So that's me done with the presentation. I am going to, crikey moly, try and answer some of these questions. Sharon is going to stop me from talking when I've gone on too long, and she's ready for a tea. Let's have a look. Okay, that's I'll answer that question personally because that's something else. I love to send links of any good videos to my patients. I'm no good at making them myself. I've tried trolling the internet. Yeah, I've got loads of patient videos, and they're all going to come up next time in Push Don't Brush. So yeah, we'll come on to those next time. Are we able to get a screenshot of the quote stated that daily self-performed cleaning is most important, so we can easily print it off? Yeah, absolutely, you can. I'll go back and bring that up so you can take a screenshot of it. Let's move down. Will we be allowed to use the test drive in the patient's mouth? Yeah, I knew this question was going to come up. Well, the current guidelines are that oral hygiene instruction is considered very low risk, so we can carry that out at either 2 meters or wearing just basic PPE that we wore previously. The Oral-B test drive it's been so robustly tested, and you cannot imagine what it had to go through to get past to be able to be used in surgery anyway. I think what you're referring to here is the splatter that's created, which is not an aerosol, it's splatter, and therefore normal PPE can be used. So I think this will come down to personal choice about whether you feel happy and comfortable. There is nothing in any of the guidelines that says that we can't do this. I imagine that Oral-B will be coming up with some statement at some point. You need to make that decision about whether you're comfortable to do that. There's nothing in the guidelines to say that you can't do that. I absolutely will be continuing with my test drive in my patient's mouth. That's me personally, and you'll need to make a decision on that on a patient by patient basis. We're going to cover that in a lot more detail next time I speak to you. What about smokers and BPE? Yeah, I mean, like I say, it works in most cases. With smokers, I tend to draw on their plaque scores more than their bleeding scores. Any suggestions on how to record bleeding scores without chairside assistance? Yeah, hopefully that's all going to change, isn't it? What I would say to those clinicians is it's okay to estimate these scores. So we can eyeball this, right? We're looking patients' mouths all the time. If they haven't been incidentally cleaning, you're already at 50%, aren't you? So it's okay to estimate it. You just need to write down that it's estimated in your notes. So bleeding score estimated at, and that's okay as well. So that would be my advice on the very rare occasion that I find myself without a nurse, and it is very rare. That's what I do. I just estimate it and tell the patient that I've had to estimate it as well. Do you do full mouth or modified bleeding scores? It depends what I'm dealing with. If there's a perio patient, then it's going to be bleeding on probing. I'll do a marginal bleeding index where there's gingivitis. It changes. Depends what's in front of me and what I'm dealing with, really. How do we fit all this into our appointment times, especially with no nurse? This question comes up all the time. You can only do what you can do. You have to prioritize. You have to decide what's important to you, what's important going forwards. So if you've only got 20 minutes, then I would be spending 15 of those, if that's what it takes me, getting this right, and then either rebooking the patient, or when they come back next time in 6 months' time, then I'll pick up. If you do the groundwork now and do less of the scaling, or less of the least important bit, then gradually you'll catch up, and there'll come a point where you don't need to do all of this, and then you've got a whole appointment to do your stain removal or whatever you do. For me, not addressing this because you haven't got time, this is like, for me, this is like a dentist finding caries, let's say, under a filling, and he's only got 20 minutes, and saying, well, I only had 20 minutes to put the filling in. The patient wanted the filling. I only had 20 minutes, so I just had to put the filling in. I didn't have time to remove the decay. I mean, they'd be strung up for it. We'd be screaming out about that. But for me, it's the same thing. If we don't address this underlying problem, the one thing that's causing the problem, and we paint over the cracks every time they come in, then the problem's never gonna get better. And for me, that's not the right way for me to work. I wouldn't be able to go to sleep at night. So it's about your explanation, it's about your communication, it's about getting the dentist on board so that the patient is prepped and primed before they even come in your surgery, so that you're managing their expectations. You can't do everything in one appointment, especially if it's a short appointment, and especially if you're somebody that's going back to hand scaling. It's going to take longer, it's going to take time. You can't do what you used to do in that short amount of time. So it's about managing expectations and managing your appointments, and tell the patients what to expect, tell them what you're doing and why you're doing it and what's to come. If they choose not to come back for that appointment, then that's always a better situation to be in than if they never actually even got that information in the first place. That's me. That's how I would handle it. I'm really confident, and I have really approachable bosses as well. I just don't think that time, whilst it's a very real problem, I don't think it's all of the story. I hope that kind of answers your question. I'll be returning to work next week. Will your next webinar be recorded, as I don't want to miss it? Yes, I believe it will be recorded. It would be good if you did this lecture at the BDA. Listen, Lisa, I'm open to it. Just tell them to give me a call. Would you do this under normal circumstances on first visit, or get the patient to brush it off? I'm not sure what you're referring to then. There, maybe disclosing, I'm not entirely sure. On the disclosing image, is there something covering the patient's lips? Yes, there's an Optrogate covering the patient's lips. That's to do with the type of treatment, GBT, that I do. I just like Optrogate. It holds the soft tissues all out of the way for me. Yeah, and they're certainly going to be used a bit more by me going forwards. What do you tend to say to the patients that complain that you've done too much assessment and too much talking and not enough scaling and polishing? It's the same answer. Sorry, but this is my job, this is my role, and quite frankly, if they don't like it, it's not the way that I'd say it to patients, but it's the most important part of what I do. I don't get that complaint very often, because I explain so well, because I have good relationships and build that rapport with patients. It's rare. I think if I didn't do all the explaining to start with, and just did the OHI and then didn't do any scaling and polishing, if that's what you want to call it, then I think I probably would get lots of complaints. But because I'm guiding these patients and educating them and explaining all of the time, then I tend not to get them complaining quite so much. Whoops, I've gone past one there. Dear Faye, would you be happy to share with us those 2 leaflets you have for your patients about? Yeah, absolutely. Gingivitis and periodontitis, absolutely. Yeah, I've no issues with that at all. They're mostly taken from various other bits from forums and other courses anyway, so I'm not precious about them at all. Sorry, Faye, I missed what disclosing solution you use. Can you repeat it, please? Yeah, I mean, there's different brands out there. Little pre-soaked disclosing pellets. So they're little tiny sponges, and it means I haven't got to get a Dappens pot and a long-handled brush and solution everywhere. Just pick them out with some tweezers, just a sponge, and wipe it on. It's really very, very quick and very, very easy. Hi, Sharon. Hello.
Hello. If we go to 20 to 6, is that okay with you?
Yeah, absolutely. Where we are. So 5 minutes. Yeah, it's absolutely fine, Sharon. Yeah. I work with lots of patients who are requiring interpreters. English is not their first language. Do you have any tips to help motivate these patients? Often things are lost in translation. Yeah, they are. I think for these patients, this is where visuals come in. This is where getting physically showing them how to clean their teeth is comes into play, isn't it? I mean, if you have a particular language, 2 or 3 languages that your patients sit into, or you know that they'll be able to understand, then I would have your leaflets translated. So I do have one in Polish because I have quite a lot of Polish patients at one practice. So that's something that you can do. It's very, very difficult with interpreters, because words that we use, although they're incredibly talented, these interpreters, it might not be a word that they necessarily understand, or it might not be a word that can be changed into a different language. So it is really very difficult, that one. How do I deliver OHI TBI with the new scope of practice and the FDGB guidelines? Yeah, we're going to go through all of that next time, saying we should be gowned as they enter the practice. Yeah, I think we're going to come into all this next. It's quite a long answer, is this. We're going to come into all this next time. So we're running out of time now. How long do you allow for an OHI appointment? My appointments are 30 minutes. So I do what I can get done in 30 minutes. And if that's only the charts and the explanation, then I'll bring them back for the OHI. If I get through the charts and the explanation and the OHI and I've got time to scale, then that gets done as well. You can only do what you can do in that time, and don't be ashamed. The dentist would think nothing of getting halfway through or doing a checkup and bringing them back for a filling, or getting halfway through a filling that ends up being a really tricky filling and temporizing it and bringing them back, and we shouldn't feel that pressure either. Oh, some really nice comments coming through. Crikey, thank you. People loving my pink hair as well. Smile month. It's all about smile month. Okay, so I think I'm gonna probably have to leave the questions there. I'm sorry that I haven't been able to get through all the questions. I'm very mindful of poor Sharon, who's given up all the time yet again. If you want to contact me, I'm always on the forums, or you can private message me. You don't have to, it doesn't have to be a public question. You can email me, you can get in touch with me, Instagram, whatever it is. I'm always happy to help absolutely anybody that I can help. I think times like this, we really do need to stick together and help each other. So particularly with the new guidelines, if you're struggling, I don't have all the answers and I don't claim to have all the answers, but sometimes it's just nice to have somebody else to talk to, isn't it? So
I think
sorry, I can't answer all the questions.
I think that's the policy that BSDHT have adopted as well. You know, we don't have all the answers, but sometimes it's just speaking to somebody that sort of understands where you're coming from, or you know, just lends an ear for, or you know, shoulders to cry on sometimes. So, thanks ever so much for that, Faye. Thank you to Oral B for sponsoring it. You should, as you exit, you should get directed to a survey. If you can fill that in, I plan to do the certificates on Sunday, but I'll also send the link out probably tomorrow as well, just in case you sort of log out and it does direct you. Okay. Have a good evening, everybody. Thank you.
Bye, everybody. Thanks for listening. Bye, everybody.
Bye. Bye.